Greetings, panelists and participants. My name is Victor Mwansa. I'm a project associate at Africa Air Business. I would like to welcome you to this virtual official side event happening on the sidelines of the International Conference on Public Health in Africa happening in Lusaka, Zambia. The side event is organized by Africa Air Business and Terumo Blood and Cell Technologies. The session goes by the title Advancing Public Health in Africa, Redefining Blood Transfusion Therapy and Sickle Cell Disease Management through Innovative Red Cell Excellent Technologies. To start off, I'd like to highlight some guidelines for the session. Attendees will be on mute during the session. This session will be live streamed on HB YouTube account. The session is in English and will last for 2 hours. Feel free to post your questions in the Q&A session at any time during the session, and they will be responded to as much as possible. Participants are encouraged to tweet during the session under the hashtag CPHIA 2023. To highlight the session agenda, we will have 6 panelists, a moderator from Africa Air Business, a keynote video by the Terumo BCT CEO, and 4 speakers from the Ministry of Health Uganda, National Blood Transfusion Center, Cote d'Ivoire, and Zambia National Blood Transfusion Center, and Terumo BCT. Thereafter, we'll have a Q&A session, party shows from the panelists, and therefore, and finally concluding the session. Before I introduce the moderator for the session, our team would like to play a video of the patient living with sickle cell disease who has lived in both Nigeria and the United Kingdom. For now, enjoy the video.
Years of life, and I'm still scared of needles. I've lived with sickle cell all my life.
Sickle cell disease is an inherited genetic disorder that affects people from birth. They usually start developing symptoms when they are 6 months of age, the commonest symptoms of which are pain and also propensity to catching serious infections. Patients who are affected have red cells that are sickle-shaped when they are deoxygenated, and this comes from the abnormal solubility of their abnormal hemoglobin. Sickle cell disease affects certain ethnic groups more frequently. The commonest are in Africa and also in people of Afro-Caribbean and Afro-American descent. It is a serious debilitating illness which requires lifelong treatment and a lot of support.
Hi, I'm here for my treatment.
A sickle cell disease pain crisis is undescribable. They ask you, what's your pain level? 10 out of 10. You go 12. It takes your breath, it takes everything. Pain keeps traveling all over your body. It's like something is pressing your heart down and your bones. I could be talking to you and then I could go straight into crisis, just that minute. You live every day not knowing what's going to happen.
The disease will always keep showing its face unless steps are taken to modify it.
Let's have a sequence that you have 100 down.
A patient with sickle cell disease will always feel tired, and there's always the threat that a painful crisis might come out of the blue. People lose their confidence, sometimes they are unable to attend school, and some people find it difficult to maintain stable employment.
As a young child, it was really hard. I really didn't have a lot of friends. I'm the 3rd child of 5 from my family, but the only one with sickle cell. It means my parents had to dedicate their life looking after me. I gave up on relationship at some point, to be honest. By the time people find out that you have sickle cell, you just realize that they don't pick your calls anymore. But when my husband came along, there was something unique about him. We met at a bus stop. About 4 to 5 months into our friendship, I told Abby I have sickle cell.
When Bola did tell me that she suffered from sickle cell, I imagined that it was just something that could be easily treated or something that could be cured. But she insisted that I met with a sickle cell counselor, and that really enlightened me on the impact on sufferers and the families.
I was like, this guy does not know what he's getting himself into. He still went ahead. He still wanted to marry me, and he has been my rock. Growing up in Nigeria, the treatment I could have then was just blood transfusion and painkillers. That was it. Moving over to the United Kingdom, I was able to access more treatment. 3 years ago, I was close to dying. I had a serious chest infection. It was pneumonia. I was in ICU. Nothing was working for me again, nothing. And my consultant decided that, okay, Bola, we've tried everything. I'm going to put you through exchange blood transfusion. And I remember we just started to see the difference.
Automated exchange is offered for patients who have had strokes before, who've had recurrent chest syndromes before, and anybody else who's not doing too well on whatever treatment we're giving them. The automated exchanges are important because they give patients a much better quality of life. Some patients have been completely free of hospital admission since starting on the exchange transfusion program, which is a huge achievement.
Sharp scratch. Keep still for me. She's got a tricky vein there.
The machine is able to separate what the doctors want to go in, what they don't want to go in. The treatment tends to last for about 4 to 5 hours. But after that, when everything is mixed up in my system, I'm good to go. Hospital used to be my second home without the mortgage. But now I don't have crisis. I have more energy. I'm here for my husband and my children. My parents look at me today and I just see joy.
This has been life-changing for her. Ever since we started this just over 3 years ago, she hasn't been to hospital admitted acutely since, which is a huge achievement, and she's been able to get on with her life and get on with her children.
She's more healthy. She's got more energy. The machine and all the support, the technology is great, but the blood, it's quite important.
Like sickle cell patients have got very different blood groups to those of the white population, who tend to be the majority of donors. So we're looking for ethnically matched donors to donate as much as possible.
This is why we're campaigning. This is why we're pushing for more Black people to give blood to support people with sickle cell disease. Having children, having my husband, I'm able to do what I love doing. My life has greatly improved.
I believe the video was insightful, and at this time, I'd like to introduce the moderator for the session. Malos Kibacha has more than 15 years of experience in management and consulting in healthcare sector in Africa. She's a co-founder and managing director at Africa Air Business, a healthcare consulting firm that focuses on strengthening Africa health systems via private health sector engagement. Apart from her role at AHB, she founded Imarika Initiative, a community-based organization that supports mentally disabled children in Mukuru in Nairobi. And she's also a board member at Sibusiso Foundation in Tanzania and the Coalition for Women's Health in Africa. Welcome, Ms. Malos Kibacha.
Thank you, Victor, and welcome everybody. Good afternoon, morning, evening, depending where you are from. It's my pleasure to be here and to moderate this session, and I'm very excited to learn a lot about our expert speakers. But before we do so, I'd like to, before I introduce the speakers, I would like to share a bit of a high-level overview of sickle cell disease in Africa. And as you saw already in the video, you have an idea what it is about, and I assume registering for this session, you're already familiar with sickle cell disease. Nevertheless, we wanted to share the basics about sickle cell disease in a very simple way to make sure we are all on the same page. As you most likely know, is that sickle cell disease is a hereditary disease. It can be inherited, or it is inherited by your parents, and it's marked by defective hemoglobin. The disorder disables the ability of the hemoglobin in red cells to form normally, and it creates a sickle cell shape. and that it tends to stick together, and thereby it blocks the blood from the small blood vessels, and that creates painful and damaging complications. Different levels of complications can happen. So, for example, strokes, acute chest syndrome, organ damage, and other disabilities. And in Africa, unfortunately, often it leads to premature death, especially amongst children. At the moment, there is no cure for sickle cell disease. Medicines are given and there are medical interventions done. And we are here in this session talking about one innovative intervention in the medical space linked to blood transfusion. So we're looking forward to learning more about that. In addition, ongoing research and breakthroughs are happening in terms of bone marrow transplants and gene therapy. Maybe we can zoom a bit into that also, what that might mean for the status of sickle cell disease and patients with sickle cell disease in Africa. But our main focus will be the innovative blood transfusions that is possible. So if we look at the sickle cell disease burden and statistics globally and zooming into Africa, because we are talking about Africa mainly, globally, 5% of the world population carries a trait gene that has a hemoglobin disorder. The majority of these are sickle cell disease traits and thalassemia. If you look at the incidence of sickle cell trait, it ranges quite high in certain areas on the African continent, which you can see on the map here. 20 to 30% in Cameroon, DRC, Gabon, Ghana, and Nigeria. And if you think out of the 300,000 babies born every year, 75% of these babies are born in Africa, and more specifically in sub-Saharan Africa. And without the right treatment and measures, it's estimated that out of those children, 50 to 90% don't reach their fifth birthday here in the southern parts of Africa, which is a very shocking number, and that needs to stop. And that's why we are here, not only to find partnerships together, to talk about the solutions and how can we scale the solutions to make sure that that 50 to 90% significantly reduces or even can become zero. And to make sure also that the quality of life for people with sickle cell disease will increase. So yeah, it is my pleasure to be here with you. We go to the next slide. You can get a highlight overview of what we will talk about. And it's my pleasure, and I'm very excited to have a very broad team of different panelists, experts from different countries on the continent, East, West, Southern. We have an expert from Uganda Ministry of Health. We have from the Blood Service in Zambia and also in Ivory Coast, talking about what they are doing in their countries, what is working, what has been the results, and what are opportunities to scale. Then I'm also very excited to have a speaker from Terumo here to talk about the advancements in red cell exchange technologies and how can we build capacity and infrastructure to make sure that sickle cell patients all in Africa will have access to these exchange technologies. And that will lead us also to the partnerships. What do we need to do? We can't do it alone. How can we create action-oriented partnerships? Not only partnerships on paper, not only talks, but how can we, as public and private sector, effectively and sustainably collaborate to make sure that sickle cell patients receive the treatment and maybe eventually actually cure that they need. So if we go to the next slide, I want to share with you an overview of our esteemed speakers that we have. We will start our session with a video from the CEO of Terumo Blood and Cell Technologies. And after that, I will come back and then we'll have all our speakers, panelists that are with us from the different countries in Africa. We have Dr. Oyo Charles Akia. He's the Commissioner of Health Services, NCDs at the Ministry of Health in Uganda. We have Dr. Gure Sidonis. He's the Head of Research at the National Blood Transfusion Center in Ivory Coast. We have Dr. Joseph Mulenga. He's the Medical Director of the Zambia National Blood Transfusion Service, and Dr. Hiram Mwangi, who's joining us from Kenya, who will explain more about Terumo BCT solution, and he's the Medical Science Liaison for Africa. So allow me to introduce our first keynote speaker that will talk through video. Ms. Antoinette Gavin is the President and the CEO of Terumo BCT, a medical technology company striving to unlock the potential of blood and cell-based therapies. Terumo BCT is meeting emerging healthcare challenges under Antoinette's leadership. She believes that medical device manufacturers must change and go beyond equipment to think about services, data management, and new geographies where people need access to technologies to advance their health and lives. Antoinette has over 30 years of experience directing diverse global teams and transformational change, and has led joint ventures, integrated acquisitions, and all aspects of marketing, strategic planning, and commercial operations in the healthcare, information technology, and energy sectors. She's a lifelong champion of diversity and equity, and her passion is to help people around the globe to have equal access to technologies that can advance health and their lives. So we will be showing a brief Terumo video, and in her opening remarks, she will share a bit more information why a big multinational like Terumo is focusing on sickle cell disease, and what is their strategic plan for sickle cell disease in sub-Saharan Africa. And also she will have a call to action. So over to the videos. Thank you.
When we look at the world, we see potential at every turn. We seize that potential to unlock a better future, recognizing what is and reaching for what could be, building on what we know to advance into the new. Unlocking potential is our promise and our purpose. We uncover needs, then work to fulfill them. We tap our collective potential to keep innovating, improving, accelerating, to help bring better care to more patients around the globe. We advance technologies that automate complex processes and harness data to improve access to an adequate, safe, and sustainable blood supply around the world, and support advanced clinical outcomes. We expand our blood technologies expertise to unlock the biological potential of cells and genes, helping to advance promising therapies while seeking better outcomes for patients. Every day, we dedicate ourselves to unlocking the potential of blood and cells, technology and data, our colleagues and patients, as we strive to fulfill our mission, contributing to society through healthcare.
Thank you for having me today. I lead Terumo Blood and Cell Technologies, and we make the equipment that collects and separates blood and cells. And think of the fact that everything in healthcare starts with a drop of blood, from a diagnosis that could help provide insight into your treatment and perhaps prevent some debilitating outcomes if caught early enough. Think of the therapies that you receive along that care journey and the feedback loop that comes as you test your blood to see if whatever is being done is working. And consider the fact that we each generate 9 pints of blood a day, yet thousands of people die for lack of access to clean, safe blood. That is what our technology does. But if I have technology that does not get into the hands of patients, then it is just waste. And our objective is to not just understand the uniqueness of each drop of blood, but provide the tools and equipment that helps get it safely into those patients' hands and connect it to treatments like red blood cell exchange and feed it back into the system so we learn from that data and from those experiences. When we discuss patient access requires awareness of physicians, awareness from people who are suffering from this disease and those who are advocating on their behalf, so they know what's possible and they know what to ask for. And as I have met with leaders across Uganda, Kenya, across the world, and understand what is already in place, it is clear to me that the platforms exist. You have a public health infrastructure that had been put in place to treat an AIDS crisis that can be repurposed and deployed and built from. You have the talent, the people. This is possibly the most important piece, where you have people who can make a difference. And we each bring a unique perspective and come from a different lens. So the power of connecting everyone in forums such as these is that you will think a little differently, but hopefully leave with an idea on how to collaborate and how to have clarity of purpose and ensure we make sure that people, children, mothers who have something that can be treated is treated, and it's done so in a systemic way. And the objective of these forums is to educate and inspire the policymakers and those who have the funding to direct it in very targeted ways. So enjoy the sessions, and I truly hope you leave with a few unique things that you can do to help bring this broader purpose to life. Thank you.
Thank you very much, Antoinette. I think the key takeaways that I got from her that she mentioned, technology not in the hands of patients is waste. I think that is what we are trying to avoid here. Let's use the technology and let's make it accessible to patients. What do we need for that? Awareness at physician level, at patient level, at advocate level, and the power of connection. How can we collaborate together and educate and inspire? And our first inspirator here, it's my pleasure to introduce Dr. Oyo Charles Akia. He is the Commissioner of Health Services of NCDs at the Ministry of Health of Uganda. Before then, he served in the district local government as a district health officer. I believe we're very honored to have you here with us. As we did our research about sickle cell disease and public programs to treat and manage sickle cell disease, Uganda was an outlier in the region in terms of having a robust program in place, and looking forward to hearing from you from the ministry's point in view. What is the status of sickle cell disease in Uganda in terms of the burden, and what does the national sickle cell disease program in Uganda look like? Like what are the key focus areas? And yeah, basically hearing your experience on treating, eliminating, screening for sickle cell disease and the program in Uganda. Dr. Oyo, very welcome.
Yeah, thank you. Thank you very much. I hope you are hearing me well.
Yes, very well. Thank you.
Yeah, and if the video is okay, you can also let me know. And in any case, if you need some adjustment, I'll do so. Very glad to be part of this discussion. And I bring you greetings from Ministry of Health, Uganda. So in Uganda, generally, the sickle cell program started some time back. And we have one of the oldest sickle cell clinic in the country at Mulago. But just to bring you to speed, the prevalence of sickle cell disease in Uganda is quite high. And in terms of the sickle cell anemia prevalence, it is at 0.73%. This was according to the survey that was done in 2014 and 2015. It was a national survey. And the prevalence of the sickle cell traits is at 13.3% on average, but in some parts of the region, it goes as high as 20%. So it is not uniformly distributed. It is very high in the northern part of the country, the eastern Uganda, central, and a small pocket in the western part of the country. And every year in Uganda, we have about 15,000 to 20,000 babies born with sickle cell anemia. And unfortunately, about 80% of these usually die within the first 5 years of life if no intervention is initiated. So therefore, this calls for some aggressive intervention. And I'm glad to share with you that Ministry of Health Uganda, in partnership with the different stakeholders and actors supporting government of Uganda, actually introduced a very comprehensive sickle cell disease program in the country. And this started after that national survey was done. So we knew where the burden was high. We knew where to take interventions. So it was done in a very focused way, and that contributed to the picture that we currently see in the country and in the region. So how were we able to do that? First and foremost, we had a very strong political commitment and leadership of the government of Uganda, starting from the top. At the ministry level, our minister is a pediatrician, and she's a public health specialist. She's very passionate about sickle cell disease program. She has been the champion of sickle cell disease fight in the country. So, you know, once you have the political leadership behind you, you are bound to succeed very, very well in any intervention that you undertake. So arising from that, we were able to, we started by developing a policy and a strategic plan to guide our implementation of the sickle cell disease program in the country. But that aside, we had a very strong partnership with the cultural institution, especially Buganda Kingdom, where the king himself and the team was very, very, very strong behind us in the mobilization activities. In 3 consecutive birthday celebration for the Kabaka, he has been able to offer, you know, the program strictly to mobilize the subjects, to raise awareness, and also do, you know, screening for sickle cell disease. So this has been very, very instrumental in some of the achievements that we have noticed. Besides that, as a country, we established over 100 sickle cell disease clinics in the high burden areas to do screening for the newborn, for sickle cell disease, and also provide the care that is required. But there are also other interventions that we have supported us in reducing mortality related to sickle cell disease, like introduction of the pneumococcal vaccines that is offered free of charge to all the children in the public and the private facilities. And to streamline the management of or coordination of sickle cell disease program, we established a sickle cell disease technical working group at the Ministry of Health, headed by the national coordinator, who is also a very, very instrumental person in coordinating this program and also mobilizing the partners and resources from within and outside the region to support this program. Besides that, we have, as a country, a very robust laboratory sample transportation system. This lab system was established under the HIV/AIDS program, but later on it was able to take care of all the different samples that are taken from across the country and transported for confirmation at the national or the central public health laboratories or the capital city in Kampala. So that system is working very, very well, and it goes down up to the lowest level at the sub-county levels. So in other words, we have a very, you know, very clear system of getting samples from all over the country, and these samples are brought to Kampala. Results are released using the rapid, there's a laboratory dispatch system that sends the results back. It is an online system, but sometimes I know because of hiccups in the internet connectivity, we get some delays. But beside that, we establish centers of excellence for sickle cell disease care. These centers are mainly in the high burden areas. We have 10 of them in the country with over 150 health facilities. These are satellite centers to support in the newborn screening. And again, these facilities are doing us very, very good work and it is contributing to the success that we have registered across board. Now, in the centers of excellence, what do? We do basically newborn screening, and then we provide general care for patients living with sickle cell disease. We do genetic counseling, provide patients education, and also the aspect of data management, where data is captured in the sickle cell registry using electronic system and is relayed to the center. So at the center, at any one point in time, we are able to provide real-time information about the sickle cell disease patients that we have under our program. Besides that, we also established a very, very strong and reliable partnership with our stakeholders, both locally and internationally. For instance, we have Novartis. Novartis has been supporting us with hydroxyurea, because as you may be aware, some of these medicines are expensive and we're not able to afford at the moment, and using the little resources that we have as government, but they are able to come on board and support us. But what we have at the moment is a medicine for adult that is 500 milligram. But again, we are working with them a way of getting the smaller dosages for pediatric patients, that is 250 milligram, which is a square tablet. And I'm glad to mention that we are making progress in that direction. Through the partnership, again, we're able to do a lot of capacity buildings of health workers at all levels, right from the national up to decentralized levels. And there are many other actors, the civil society organization that has been supporting us in the mobilization efforts, and also doing screening, preliminary screening, using solubility tests before confirmatory tests is done at the central levels. And I know Terumo has also supported us through Joint Clinical Research Center, where red cell, technologies is being currently implemented, but that's not sufficient, and we need more to do in that direction. So briefly, this is what we have about the sickle cell disease program in the country. And maybe to conclude, at the moment we have 40 health units that are providing hydroxyurea, 40 facilities in the country. And these facilities are mainly in the high burden areas and doing quite a very good work. And that has brought a lot of improvement in terms of the quality of lives of the person living with sickle cell disease, and also reducing the mortality associated with the disease. And of course, that is about what we did. But nevertheless, we still have some challenges in the care for patients living with sickle cell disease. Generally, the level of awareness is not to our expectations. Not the entire country is very aware of the disease. So we need to do a lot more in that direction. And we have also noticed that capacity building is still something that we should focus on, so that we have everybody at all levels in the country to be able to diagnose sickle cell anemia early, and also provide the required level of care that is required. And the turnaround time for confirmatory tests is still an issue, much as we have a robust laboratory system in the country. We have only one center doing this in the country. So that means when we talked of potential areas of partnership, we can explore the possibility of decentralizing some of these confirmatory tests at the regional referral hospital levels, in terms of having HB electrophoresis machine. The supply of hydroxyurea is still limited. Not all the clients who are in need of the service, of the care, of the medicine, is able to get in. So again, that is another potential area that can be explored if resources can permit. And harnessing the technologies, like the point of care devices. This is very, very important, especially at the primary health care levels, so that the public health workers, the clinician at that level, should be able to really screen early and refer the patient for care where the services are being offered. And the technology in terms of the bone marrow transplant and red cell exchange is also an area that can be supported for, in our country. But I'm glad to mention that the hurdle that we used to have in the area of bone marrow transplant has been overcome by the enactment of the the organ transplant law that is already in place, and is going to pave the way for, a lot more in this area for patients to access services for those who are in need of that. And then another potential area, of course, is supporting us, doing research to get molecules or products that are more efficacious, more affordable, that can be, rolled out to the rest of the people in the country. Because currently, hydroxyurea may not be as easily accessible as is required. So briefly, this is what we have about the sickle cell disease program in the country, the challenges and opportunities for partnership. Thank you very much. And over to you, moderator.
Thank you very much, Dr. Oyo, and very interesting, and also congratulations for the advancements made. And I think where you started, what is at the core of why your program is taking off and maybe more advanced than in some other countries, the political will that you have there from top level to inspire and to guide the rest of the team moving forward. And actually, I found it very interesting what you mentioned, that in your lab system, which was maybe initially designed to take care of HIV, is now expanded and also includes sickle cell disease, amongst others. And it aligns to what Antoinette was saying in her video as well. Repurposing certain systems, you don't need to reinvent the wheel, but you can build on the systems and the platforms that you already have. And it's very nice and interesting to hear that Uganda is doing that. And in terms of partnerships, I think that was a very clear answer that you gave. Basically, partnerships that help you increase access and affordability are welcomed. And also noticing that you are working already with different partners, but are still open to welcome other partners in the areas of access and affordability is duly noted. Thank you very much. And if the participants have any questions for any of our panelists, please feel free to type them down. Victor will collect them, and in our Q&A or our forum, I will share the questions that you guys have as much as possible. And it's now my pleasure to introduce another expert from the other side of the continent, from Ivory Coast. My French is not that good, so I will introduce her in English. She will do her presentation in French, but we have one of our team members here to help with the translation to English, so that everybody can understand and learn from the knowledge that she has. Dr. Goure Sidoni, she's the head of research at the National Blood Transfusion Center in Ivory Coast. She's a member of the Ivorian Society of Hematology, Oncology, Immunology, and Blood Transfusion. She's also a member of the French Society of Hematology and the French Society of Vigilance and Transfusion Therapy, and part of the French-speaking African Blood Transfusion Network. She's also part of the Pharmacovigilance Expert Committee. All in all, bienvenue, Dr. Sidoni. It's our pleasure to have you here, and we're very much looking forward to learning from you in terms of the status of sickle cell disease in Ivory Coast, and also your experience also as head of research linked to the introduction of the innovative blood transfusion technologies that you have introduced. Dr. Sidoni, over to you. Sheila, welcome. I believe you will take care of the English part of the presentation, so translating live. Ladies, over to you. Thank you.
Merci. Je vais faire ma présentation en français et puis on va faire la traduction. Je vais vous partager l'expérience de la Côte d'Ivoire en matière de prise en charge de la drépanocytose. Nous avons une unité au sein du Centre national de transfusion sanguine qui prend en charge les drépanocytaires. Donc, on va vous partager notre expérience. Il faut dire que la drépanocytose, on peut passer la diapo suivante, s'il vous plaît.
Next slide.
Okay. La drépanocytose représente 14% de la population en Côte d'Ivoire. Ça veut dire qu'il y a 14% de la population qui porte le trait S de la drépanocytose. Et nous avons une population qui est estimée à 29 millions d'habitants. Et 2% de la population porte le trait majeur de la drépanocytose. Et c'est l'haplotype sénégal qui est le plus présent. On a un centre de prise en charge qui est au CHU de Yopougon, dans la ville d'Abidjan. En 2012, on a ouvert un centre de prise en charge de la drépanocytose au sein du Centre national de transfusion sanguine. Et en 2012 et 2016, on ne pratiquait que la transfusion manuelle dans ce centre de prise en charge. Et à partir de 2016, avec l'acquisition de 2 machines d'aphérèse, nous pratiquons aujourd'hui l'érythraphérèse sur les spectra optia de Terumo BCT. Nous allons vous présenter les résultats de l'implémentation de l'aphérèse au sein de l'unité de prise en charge de la drépanocytose au sein du Centre national de transfusion sanguine. C'est une étude prospective et descriptive qui s'est réalisée au sein de l'unité, qui a duré du 4 janvier 2018 au 31 décembre 2022. Nous avons environ 680 patients qui étaient inclus qui étaient au niveau de l'unité, et on a 116 patients qui ont fait des échanges sur le spectra optia.
Je vais faire la traduction de ça.
D'accord.
Yeah. Maybe I can just summarize what you mentioned in the previous slide about the methodology that they're currently implementing and have found success is through a prospective or descriptive study, which is managed by the CNTS Transfusion Therapeutics Unit. And this was a study conducted between January 2018 and December 2022, where they found that 680 sickle cell patients in a long-term program at the unit, and then 116 sickle cell patients underwent apheresis on the Optia, the Terumo's Optia device.
Quels sont les résultats que nous avons obtenus? Il faut dire que nous avons eu seulement à inclure 34 patients dans notre étude. Et les patients avaient un âge qui était compris entre 5 ans et plus de 30 ans. Et le sexe masculin était prédominant. Le phénotype hémoglobinique XS était le plus fréquent. Et on a vu au cours de nos patients avaient un hématocrite qui était compris entre 18 et 60%. Le maximum de hématocrite, s'il vous plaît. Et là, vous avez l'évolution du taux d'hématocrite avant l'échange transfusionnel et après l'échange. On a vu une augmentation du taux d'hématocrite, et au niveau du pourcentage en hémoglobine S, on a vu qu'il y avait une diminution du taux d'hémoglobine S après les échanges par l'érythraphérèse.
Yeah, so the study results were based on a group between age 5 and 30 years old. And they also disaggregated the data between male and female. And they also conducted the analyzed data on hemoglobin, the phenotype hemoglobin, as well as hematocrit, as well as the S-trait hemoglobin.
Donc, qu'est-ce que nos résultats nous montrent? Qu'on a une bonne évolution clinique des patients qui ont été mis sous aphérèse, et il y a une forte demande de l'utilisation de l'érythraphérèse. L'activité était très intense. On avait environ 3 patients par jour et par semaine. Donc, mais il y avait des facteurs limitants à l'inclusion des patients. Il y avait le coût élevé des kits, Et on avait des aiguilles qui n'étaient pas adaptées pour les voies veineuses périphériques. Et il y a aussi le manque de formation adéquat du personnel de l'unité. Et on avait aussi un problème de maintenance au niveau de ces appareils compte tenu du taux élevé d'humidité et de corrosion. Et aussi, on avait un problème de maintenance par le manque de formation des techniciens biomédicaux pour l'entretien des appareils.
So what they did during the study, they did a trial on 3 patients per day for 4 days every week. And this was a very intense program. And what they achieved with a considerable patient improvement was high demand for hematology services for sickle cell patients. And some of the limiting factors to the study were the high cost of the kits, the need for good venous access, placement of a central catheter or arteriovenous fistula, cramped conditions of the ETT, and then insufficient blood productions, device maintenance problems, due to the fact that some of the health facility workers do not have this capacity to be able to do that maintenance or conduct maintenance services for the device. And then there were also issues to do with the high humidity levels, leading to corrosion of some parts of the device, as well as the risk of dust depositing on the sensors, causing malfunctions in the study and interpretations, and instability of electric current, as well as cramped premises of the CNTS transmission therapy unit, which creates a need for new premises.
Quelles sont les perspectives? Il serait souhaitable que nous puissions avoir une diminution du coût des rétraférèses pour qu'on donne la possibilité à beaucoup plus de patients de pouvoir bénéficier de cette thérapeutique nouvelle. Nous également, nous demandons un plaidoyer auprès du CNTS afin de revoir le coût de l'échange à la baisse. Un plaidoyer également au niveau des assurances pour permettre une bonne couverture de la prise en charge par cette thérapeutique et également former le personnel soignant afin de pouvoir avoir la capacité de prendre en charge correctement les patients qui seront inclus par la thérapeutique par l'érythraphérèse. Et également, nous demandons également à Terumo BCT par rapport à l'Optia de pouvoir donner la capacité à nos ingénieurs biomédicaux pour pouvoir assurer la maintenance de nos spectra Optia.
So from the study, it became apparent that the strategies to make apheresis accessible included the fact that the CNTS bears 70% of the cost of support, which is estimated at €300. And there's need for free pre-transfusion biological assessments and advocacy with the state to increase the quota for CNTS and reduce that of the patient, as well as advocacy for health insurance coverage and construction of new premises to increase the number of patients and to be treated, as well as capacity building of user personnel at the facilities, as well as Terumo training of biomedical technicians in the maintenance of the Optia solution.
Là, je vais vous présenter un cas clinique d'un enfant de 10 ans qui est drépanocytaire majeur SS, de sexe masculin, qui était suivi régulièrement au CHU de Yopougon et qui nous a été adressé en 2015 face à une hémiplégie avec une aphasie. Et il a été pris en charge avec des échanges manuels. Il avait comme taux d'hémoglobine de base 8,4 grammes par décilitre, avec une hématocrite à 25% et le taux d'hémoglobine S était à 92%. Il a bénéficié d'un échange manuel par mois et après 8 mois, nous avons eu une récupération de l'hémiplégie avec un score à 3 sur 5. Et il y avait une répétition des crises et malgré les échanges. Et en 2016, il a commencé les échanges érythraphérèse sur machine et il a bénéficié de 3 échanges sur machine. Et après ces 3 échanges, nous avons eu une récupération totale de l'hémiplégie avec une récupération, l'aphasie a complètement régressé et nous avons constaté une diminution du taux d'hémoglobine S qui est passé de 92% à 48% et un taux d'hématocrit à 28% et le taux d'hémoglobine à 9,2 grammes par décilitre. Donc, il y a eu vraiment un effet bénéfique de l'érythraphérèse sur ce jeune homme de 10 ans et qui est là aujourd'hui, qui a récupéré totalement de son hémiplégie et qui a un langage qui est correct.
So there's a case study which shows a success story from this solution, which involved a 10-year-old child, male child, who was suffering from sickle cell disease and was receiving treatment at the Yopogun University Hospital. He experienced a stroke in 2015, and then this was addressed to the UTT of the CNTS in Abidjan for transfusion exchange. And what they realized was a baseline of 8.4 hemoglobin. And looking at the manual protocol, there was a benefit from the treatment was that there was 1 exchange per month, which led to a depletion of 7 ml of hemoglobin. And what they realized is a modest recovery after 8 months of manual exchange, including motor skills. And the recurrence of stroke reduced during this period to a span of after 6 months from the exchange. And then the erythrocyte apheresis started in May 2016, which entailed 3 exchanges within an interval of 30 days. And on average, 1,100 milliliters of CGR at each exchange, which meant a depletion of 300 ml of blood. And eventually what they realized is that clinically total recovery of motor skills and speech after 3 exchanges of red blood cell, and the hemoglobin of 48% and hemoglobin of 9.2 with the HDE at 28%.
Ben, mon exposé vient de prendre fin avec ce cas clinique et je vous remercie de m'avoir permis de participer à ce webinaire qui est en anglais et je m'exprime en français. Donc, je voulais dire que les échanges d'hématies ont un effet bénéfique sur un effet bénéfique par rapport aux échanges manuels. L'implémentation de la technologie en Côte d'Ivoire a permis une meilleure qualité de vie des patients drépanocytaires, mais le coût du kit reste encore un frein à l'inclusion de beaucoup d'autres patients à cette thérapeutique. Donc, il serait souhaitable que nous ayons un partenariat public-privé pour permettre de pouvoir inclure le maximum de patients pour une meilleure prise en charge de la pathologie. Je vous remercie.
On behalf of Dr. Gore, she would like to thank you very much for making her part of this conversation and initiating continued partnerships, public-private partnerships towards providing innovative technologies and solutions for sickle cell disease. And in conclusion, the red blood cell exchanges from the case studies and the trials on the machines indicated that they are more efficient than manual exchanges. And this technology implemented at CNTS Côte d'Ivoire has improved quality of life of patients. However, there is still high cost of kits and lack of subsidy for treatment of the disease by the state limits accessibility to this technology for majority of sickle cell patients and generally from modest social classes. So clearly this brings out the need for more enhanced public-private partnerships and increased financing for these solutions. Thank you.
Merci beaucoup, Dr. Sidoni. We'll get back to you, I'm sure, with questions, and thank you also, Sheila, for the interpretation or the translation. I think what struck me from your presentation is the reality on the ground. We talk about patients. When you critically look at it, they are patients, yes. These are children. If you look at the study Dr. Sidoni has done, the average age is 14 years. And the case study she presented is a 10-year-old boy with a stroke, you know. Sometimes we talk about numbers and patients and it loses a face. But when you think about this, the majority of the patients are actually children. children who don't have the ability yet to stand up for themselves and to create awareness of what they are going through. And I think that is why we are very happy to have Dr. Sidoni here to also share actually the data, but also not necessarily giving a face, but giving us the realization these are children we are talking about, majority of them that go to a hospital with a stroke. And if after 3 of these exchange therapies, recovery is happening, let us be the advocates for these children who don't have a voice yet, because simply they are children. So thank you very much, Dr. Sidoni. If you have any questions for her about the research, the study, the patients he's been seeing, please type them in the box. Victor will bring them to me in the forum session. Thank you, Sheila. Maybe you'll come back to help with translation later in the forum session. But for now, I'm very happy to welcome our next speaker, Dr. Joseph Mulenga. He's the medical director of the Zambia Blood Transfusion Service, also working on the innovative blood exchange. And as the medical director of the Zambia National Blood Transfusion Service, he has managed to source and implement the rapid strengthening of the blood transfusion service under the PEPFAR program. And he implemented and extended this project in terms of blood transfusion services, which culminated in the implementation of a centralized blood service according to WHO guidelines. He is a member of the American Association of Blood Banks, the African Society for Blood Transfusion, and a Medical Association of Zambia. Welcome, Dr. Mulenga. I hope you are there.
I'm there, yes.
Yeah, perfect. See you very well. You have first-hand experience, maybe not from the research aspect, but from the implementation level, Ministry of Health, Zambia, but also the National Blood Transfusion Service. Could you share more information about your experience of how was this innovation introduced, your experience with it, and how has the government of Zambia been able to finance it? We heard from Dr. Sidoni, financing is a challenge, and indeed it's not cheap, right? But how is Zambia able to do it? So I believe you have a presentation to talk us through your experience.
Okay, we can go to the next slide. Okay, the driving factor in terms of support for the National Blood Service is the demand that has been brought about by the government introducing more specialized medical services in Zambia. If you look on the slide, on the left side, there will be basic medical services, which normally would require that 1% of the population are blood donors for you to meet the needs of the country. But once you introduce more specialized services, you need 2% of the population to be active blood donors. Zambia's population is 20 million now, so that translates into, from what originally could have been 200,000 units of blood to now we're aiming to get to 400,000 units of blood. Now, in these specialized services, apart from oncology, hematology, renal transplants, and cardiac surgeries, there's also the issue of sickle cell disease, which is really a big, big problem. As we've heard from the previous speakers, it's really homogeneous across sub-Saharan Africa, and the challenges are the same in terms of prevalence, but also in terms of, complexity of managing, these services. Because once you start implementing these services, the number of units of blood that you require per patient, goes up maybe 4 or 5-fold. But also even the quality of the products that you need to perform some of these procedures also become more and more demanding. In terms of the red cells that needs to be processed in a specific way, making sure that you reduce the chances of not only transmitting infections, but you're also reducing the chances of alloimmunization because of the multiple antigenic exposures, because of the multiple transfusions or a high number of units per patient that you are introducing into the patient as you try to manage these diseases. So as a response for Zambia, really, we try to engage in automation, both in terms of processing the blood, but also in terms of testing for transfusion transmissible infections. I must say from the outset that the Zambian Blood Service is 100% government funded. We transitioned from being heavily dependent on donor funding initially by the European Union up to 2004. And then we went on to get supported from the PEPFAR, as you mentioned, up to 2016. Now, from 2016 onwards, it's been 100% government funded. What we've achieved in Zambia is a commitment from the highest political office, starting from, the leaders themselves, Minister of Health, and also the various stakeholders. There is 100% commitment, but also engagement with the government in terms of fighting for resources that are from the government-approved, parliamentary-approved budgets that are dedicated specifically to support the blood service. So this has been, our focus to ensure that as much as possible, the bulk of the needs of the blood services in Zambia are supported through local generated resources through government. The other aspect is how we acquire the equipment and how we deploy these technologies. We realized way back that as long as we kept buying equipment with no specialization in terms of maintaining them, especially this high-tech stuff, that are now being deployed and ever evolving, in terms of their complexity and their operating and then maintaining them. We could not cope up, in terms of, managing the equipment and servicing in terms of downtimes when we have downtimes. So what we did in Zambia is to come up with a policy that whoever gets consumables and paid for by us should supply their own equipment. So we engage manufacturers and the vendors of this equipment that they themselves deploy the equipment, their technology, and then we work out, a budget, how they can recover their costs through, the consumables that are used on this equipment, such that all the equipment we have in Zambia at the moment in the blood service are highly specialized, but also are owned and managed and serviced by the manufacturers through their local agents here in Zambia who are trained to try and perform, and support our operators on a daily basis, troubleshooting when there is downtimes, but also timely feedback whenever there's a challenge in the lab. As you're aware, this high-tech equipment in the Zambian scenario or African scenario face a lot of challenges in terms of dust, just maintaining the right temperatures in which they optimally can operate becomes really challenging. So what we've done is to delineate this responsibility so that we focus on our role, which is provision of safe and blood products to all the hospitals in the country, and let the people who manage the machines do their part, whilst we are more closer to their clients, who are the patients and the prescribers of blood and blood products. Next slide. So what we've deployed really is a Terumo BCT platforms. The first game changer in as far as meeting the needs of our patients is a Revios that was deployed. It's a state-of-the-art automated integrated system that in one spin can produce 4 units of blood processed into plasma, red cells, as well as platelets, and residual leukocytes, which can be used for research or also for therapeutics. So in truth, you get about 4 products in one run. This machine is an incredible revolutionary equipment that really answers, to the challenge of making the various components of blood timely in an efficient way to the patients. It's not just the quantities that are processed in a timely way, but also the quality of the products. The red cells are leukodepleted with minimal or no contamination with the leukocytes, which cause HL or alloimmunization, as we know. But also, when we talk about the quality of the platelets, they are pooled using a sterile docker. From the 4 units you can put to get 1, which is sufficient to get an optimal therapeutic dose that the clinicians need. The platelet yield index is indicated, and also you can get the data about all these products using the automated, integrated management system that is also part of this system, this equipment, this technology. We've deployed these machines at the headquarters now. We are in the process of rolling out. This has made it possible for us to be able to have these high quality products available to cover all these patients, including the sickle cell patients, and also to manage PPH, which is really a very big problem in Zambia. We've developed major obstetric hemorrhage protocols that we are managing through packaging of components as Pack 1, Pack 2, and Pack 3. 4 cells, 4 FFP, Pack 2, 4 cells, 4 FFP, and 6 platelets, Pack 3, depending on the hemodynamics in patients, bleeding mothers who are undergoing PPH. So that is one piece of equipment we've deployed. The other piece of equipment is the Optia. Optia really is a revolutionary equipment in terms of the capacity for performing red cell exchange, which has actually provided the answer to the sickle cell challenge and management of sickle cell patients, but also just to also manage, other patients that require therapeutic plasma exchange, which we have also rolled out using this equipment. And now we have a competing demand between the red cell exchange and the therapeutic plasma exchange, making it an imperative for us to roll out and scale in terms of equipment and also rolling out throughout the country, this technology, which addresses the issue of sickle cell disease, but also patients who benefit from therapeutic plasma exchange, such as, Guillain-Barré syndrome, myasthenia gravis, a lot of autoimmune diseases that now, we're able to offer to our patients at the moment, causing a huge demand from the clinicians. So obviously this has been communicated to the government and been appreciated. So they have actually supported us in first of all, ramping up our donor campaigns, raising the number of blood donations that nationally now needs to be activated to almost, fourfold in terms of the number of donors that we need to deploy or, target for us to be able to meet the needs of our patients. The other piece of equipment which is in the middle there is a Mirasol, ultraviolet pathogen reduction technology, which has got the capacity really to reduce all these microbes that are blood transmissible, including malaria, from parasite bacteria and viruses. So we did a small study with the American Association of American Association of Blood and Biotherapies to see the use of ultraviolet treated red cells and platelets to see if this technology can replace the irradiation that is normally deployed to do the leukocyte reduction, but also to prevent the possibility of transfusion-associated graft-versus-host disease. So there's a small pilot that we did here, and I'll be giving some of the details and the data that was generated in the different patient cohorts. It was funded through the Sandia Laboratories of the US government, and with support, of course, of consultants from the American Association of Blood and Biotherapies and some consultants within Africa. Next slide. So this picture, like everyone else has demonstrated, shows the benefits that have been shown to the patient that have benefited from red cell exchange. This was our very first case of red cell exchange in Zambia. This was a patient who was severely sick with stroke and unable to go to school, was always at home with multiple hospital attendances. I think the parents had almost given up hope. When we introduced this alternative to treatment, it was difficult first to convince the parents what red cell exchange was, but with the counseling, given the short period in which they were given to make a decision, we pride ourselves on the fact that we were able to be allowed to have access and consent for this patient, because immediately after the procedure, this is the face you see. The difference was like day and night. So we use this as a case for testimony, so that, we can use it to bring awareness to benefits of the patients, awareness to the clinicians who, up until this moment, had never really experienced red cell exchange as a form of therapy for sickle cell disease. But as well as just bringing to the attention of the larger public and the the funders who are government, the benefits of what changes and impact that these procedures can bring in the management of patients. Up until now, as was described in the Ugandan scenario, it was mainly hydroxyurea with support from Novartis. The same sort of strategies that are being deployed in Uganda are also being deployed in Zambia, but it's managed, of course, by Sickle Cell Task Force. For us as a transfusion institution, our role is really to provide the products to the patients, safe products in adequate quantities, but also to host these technologies and process the products and perform the procedures that are bringing about these improvements in patient care. The second case, which is below there being shown, is a case of a pregnant mother who is a sickle cell disease, went into a crisis when pregnant, and she consented to have the procedure done on her on 2 cycles, and she delivered through cesarean section successfully, having been supported through red cell exchange, which improved her circulation, which improved her well-being, and she was able to withstand the operation successfully without any untoward occurrences or adverse events. And now we see in the picture, that's a baby. She's a very healthy, bouncy, glowing baby whose life, and as well as with the mother, has been, brought to this quality through the intervention that we did through the cell exchange, demonstrating how important this technology is, but also to answer some of the challenges and lessons learned is really that, one, owning the equipment really is unsustainable because this is very, very expensive equipment, sophisticated. It cannot be managed by physicians or nurses or biomeds, or for that matter, biomedical engineers that are trained in hospitals who are trained to be masters of all equipment, starting from Olympus with Japanese, going to Etish, which is Germany, coming all the way to all this technology. Where would they find time to be experts on this equipment, which is so varied and sophisticated in their very nature? But also, when there is an improvement in the technology and the higher versions are attained, with more optimal performance in terms of throughput, what do you do with the first equipment that you bought? It means you're going to become redundant or obsolete. Now you're going to spend more money to acquire new equipment. In fact, the business case for Africa in terms of acquisition of this does not hold water. I would advocate that we engage more in terms of placement contracts that are supported through a well-costed budget or business case, where the suppliers of the equipment manage the equipment, troubleshoot, train the operators, and they're paid through the consumables. You can work out the numbers to make sure that there's a business case that makes business sense to the suppliers. I always say that there's a lot of technology that goes into development of these sophisticated machines, from concept design, the whole getting an end product. And it's costed, of course, X number of dollars to get to a finished product. And there is a recovery period where they need to recoup their costs. So if you bought cash, it means the manufacturer has made his money in one transaction. What is the commitment for aftercare service for them? Even if you go into service contracts, they have got varying degrees of success, but it means you are putting more stress on the budget to the government. Most of these politicians believe in us when we say, you spend this money, buy the equipment. Now you start going back to say, now you need to allocate a budget also for service contracts, which are also very, very expensive to manage in our part of the world. And also enforcement of the same contracts and the downtimes. Usually the experts are out of the country. They may not be even domiciled in the country where the equipment is. So the beauty about our model is that they have managed to capacitate the local engineers who are 24/7 available to us, and they come and respond as we perform the procedures on this equipment. We're 100% government funded, as I say. You need to lobby the politicians. We have got high-level presence in the government. We lobby at all levels. but also the service itself. It's a government institution. We have tried to compare, working with as an NGO, for example, the Red Cross, or a welfare organization like it is in Zimbabwe, responsible for running the service and then trying to recover through a cost recovery system for hospitals. In Zambia, we didn't feel that that would suit us. That is why we felt government should be responsible, because if for any credible healthcare system to be successful, you need a robust blood transfusion system that cuts across. And for that level of awareness, I think the politicians need to be aware. That's why we have insisted in Zambia that the blood services are a government institution. If there's any investment that comes, it's just a add-on, it's a bonus, but the bulk of the services, the funding should come from the government. Next slide. So this is a small study that we did with that I alluded to with the Association of Blood and Biotherapies that was funded through the Sunday Labs. And we had 3 patient cohorts. The sickle cell cohort with red cell exchange were about 500. That was the target for the 6 months project. And then we wanted to use to try whole blood through ultraviolet pathogen reduction using the Mirasol. So 200 neonates and then 75 oncology patients with platelets. So we did that. We were able to achieve 100% in neonatology. We were able to achieve 100% apheresis platelets. The sickle cell implementation of the red cell exchange encountered a bit of some inertia in that the clinicians themselves were not aware of this disease. So we needed to, in this procedure and form of therapy, so we need to start now educating the clinicians, but also the issue of just getting our staff ready and organizing and all the consumables and everything. But really, the major problem was the prescribers. There was a bit of, the response time was a bit less. Having said that, though, this is now, a form of therapy that is now continuous. We've continued to implement it as a routine measure beyond the project. So if you see now, in the project, we had covered about 57 patients, but as we stand now, we are over 72 patients that are ongoing. So we get this request now on a daily basis for red cell exchange. But of course, it's limited in that it's just in the capital city at the moment. So our challenge now is to roll out throughout the country. We have 10 blood transfusion centers. So we're planning to roll out to 2 centers next year, and in the next 4 or 5 years to have all the centers in Zambia have the Optia, the Rivers, and all this technology rolled out, so that we cover the whole country and can cover all the patients that will need this intervention, adequately covered for equity. Last slide, I think. This just shows the different patient categories by months, by age that benefited from the red cell exchange, totaling 72 all as we stand today. The bulk, of course, are children in that age group, and then the second age group, 6 to 18 years, they form the largest group. And then we have parents, the mothers, pregnant women, some physicians who benefited, and nurses. So this is where we are as Zambia, and our goal is just now to roll out, this intervention throughout the country and make it sustainable. I rest my case. Thank you.
Thank you very much, Dr. Mulenga. Very interesting information you shared. And I think the story you're giving, of course, affordability remains an issue because it's expensive equipment and the funding is not always there, but moving away from donorship to ownership, what your government has done in this case, and you're reiterating the need for high-level government commitment at the highest level in order to make it happen. That advocacy, that lobbying that you are constantly pushing for, I think is bearing fruits for you. And I think it's a very commendable achievement that 100% is funded by governments. And I hope that we will be able to say that in a couple of years as well from other African governments. And of course, you know, it's a start. You're in the capital city, expanding to in the next year or some years to come, 2 clinics, and then hopefully all 10 blood transfusion centers will go there. And I'm looking forward to also to hearing from you, maybe during the open forum in terms of partnerships. How can we make that scale up happen together? So thank you very much for now. I'll get back to you later. It's now my pleasure to introduce our last panelist or speaker of today, Dr. Hiram Mwangi. He's a medical affairs professional with progressive experience in clinical practice, pharmaceutical medicine, and technology development. As a medical affairs lead for Terumo BCT in Africa, he endeavors to enable access to technologies for blood processing and therapeutic technologies for blood disorders such as sickle cell disease. He supports clinical decisions through evidence generation and connecting people and organizations to ultimately optimizing patient outcomes. Hiram, very welcome. Hope you
Yes,
are. I can hear you. I can see you on YouTube as well. Great. So we've heard about this automated blood red cell exchange, and we heard about Terumo a bit. Great to hear now from the horse's mouth. In this case, you. How do you bridge the gap, and what can you share on the experience you have so far representing Terumo and bringing these innovations to where it needs to happen, and what else can be done maybe also to scale it up further? So over to you to share your experience and maybe opportunities for partnership.
Yes, so Marlos, thank you so much for this opportunity, and thank you for hosting the session. And just as an important call out, it's very good to have blood getting a platform of discussion at this level. It's a rare opportunity for different clinical specialties to prioritize this kind of discussions, and I'm happy to have this opportunity to have that. Secondly, to my panelists who've come before me, thank you for your contributions. I think one of the 3 main highlights I have from the discussions that we've already had is number 1, the importance of a well-designed and well-resourced national program, as we had from the story from Uganda by Dr. Charles Oyo. Regional prioritization. Sickle cell disease happens to be sort of a regional affair in any geography that you look at, and it's important to be able to map out those regions and prioritize accordingly. Importance of primary care strengthening throughout the value chain or the care pathway for patients, from the epidemiological aspects of disease burden, understanding primary care provision, screening, and considerations around advanced care. From Ivory Coast, we did get perspectives about the clinical benefits that can be, observed when you apply the right kind of treatments for patients with certain clinical profiles, the degrees of recoveries that you can get, for example, in stroke prophylaxis and red cell exchange. We also did get to understand a couple of challenges and opportunities for development around access, affordability, and reimbursement situations that can be considered. And just now, Dr. Mulenga outlining the value that technology brings to improving services. And what you get to see is that with blood, it cuts across all clinical specializations, from basic clinical services to very advanced therapies. And you can see how the demand for blood tends to increase across the chain. So I think I will cover 4 key areas in my discussion on bridging gaps to enable advanced transfusion options for sickle cell disease, starting with a discovery journey to trying to understand, how can we really optimize care for sickle cell disease patients and ultimately improve their quality of life. Secondly, we'll look at the care pathway, the treatment options that exist, a few disparities that we have observed, and I think my co-presenters have called out. And my third point to focus on the elephant in the room, and that's the question of blood availability. So for technologies to benefit you, for primary care to work well, for advanced care systems to work well, you have seen the Zambian data on blood requirement or blood demand increase with additional services in the care system. What those systems require is an adequacy in blood supply, and we look at some points of the status and what can be improved. And then towards the end, I'll touch on how it is that we can collaboratively bridge these gaps. So maybe you could just highlight all points on this slide. Yes, thank you. So the journey to optimization starts with an attempt to understand what kind of disease burden you're dealing with. And from an epidemiological perspective, this will give you insights into understanding the demand and the resourcing requirements that one has to have. So different parameters to look at from incidence and prevalence. I think we had some good data from Uganda and also from Ivory Coast, and also Dr. Mulenga highlighting the kind of disease burden we face. And the idea here is to create platforms through which we could consistently document our experience. National registries would go a very long way in ensuring that our disease burden understanding is clear at any one point in time, and the kind of impact that different interventions are having. Secondly, is to look at the patient pathway. What kind of journey do patients take from being aware about the disease, their efforts to try and improve that? Secondly, how they access care from the point of screening and diagnostic confirmation, accessing routine care services such as preventive services like vaccinations, penicillin, hydroxyurea medications that improve different aspects of clinical manifestations, and how that then translates into more advanced care options. Then once we look at that, we also need to also be able to demonstrate the impact that priority interventions can have on a number of outputs. So looking at the examples we've seen, small experiences to fewer patients on innovative red cell exchange technologies. We can also pilot and see how a screening program can be idealized. The example from Uganda, I think, with the centralized testing, the sample logistics that come with that, the two-step approach to screening and diagnosis, sometimes can bring inefficiencies in the process. How can we then look at technologies that can bridge those turnaround times and take these solutions closer to the patient and ensure that we reduce that time between screening and confirmation of diagnosis and initiation of the right interventions. Then looking at how to efficiently pilot those findings and eventually collaboratively scale those programs into national situations where we can have a well-organized care system around advanced care pathways, where you can provide patients what they need at the most accessible point of care in the most effective way that ends up giving you good patient outcomes that reduce caseloads, that reduce healthcare resource utilization, and also increase patient and caregiver productivity in the community. Next slide. So in looking at the care pathway, I think here I was just trying to outline what a standard sort of summarized care pathway can look like from a pre-diagnostic stage, the diagnostic processes, routine primary care, acute and chronic care interventions. And as you can see there, supportive care is part of primary care. Various disease-modifying therapies are available, and we have gotten to hear about the challenges in accessing drugs like hydroxyurea, which can be very, very impactful in limiting some of the complications we tend to see. So it is paramount that we look at these different stages and look at different interventions that can actually prevent us from needing complex care services. And if you look at transfusion therapies, there are a number of different ways by which you can achieve transfusion in sickle cell disease, from red cell exchange, standard or simple transfusion, and manual exchange. From the one case presentation from Ivory Coast, we did see the impact that manual exchange has in terms of achieving treatment targets and resolving clinical solutions for stroke prophylaxis, and how red cell exchange changes that scenario by giving you more, better treatment outcomes in a shorter time and ensuring that patients regain their quality of life and physiological situations a little better, a little faster, and preventing complications and subsequent issues like recurrent strokes. So for patients with the indications that have been called out that would benefit for red cell exchange, really we have to find ways in which we can help them access it. It's impactful, it's important, and it does end up reducing the care system costs. There are two ways in which you can look at costing for healthcare. One is the direct costs that one encounters, like procedure-based costs. But then again, there are other indirect costs and costs to the larger ecosystem of care, like bed occupancy, resource utilization, productivity losses, and other factors that tend to then contribute to higher cost of care for the care system beyond the individual. So some care system or care pathway disparities that I could highlight, things that can actually be intervened upon, raising awareness about sickle cell disease so that people can respond to the care structures that exist for it in the right way, demystifying the implications of what we see with patients, and ensuring that patients and caregivers are well advised on what kind of actions they need to take. That will then ensure that we drive demand for diagnosis and intervention in the right way and at the right level of care. Most of these patients you'll find will be away from where these care systems are available for them. So how do we drive diagnosis and interventions closer to where these patients are? Then looking at complex screening and diagnostic processes and how we can leverage current technologies, both immunological and micro-engineered HB electrophoresis technologies, in ensuring that they can access care at the points at which they access services. And it could be integrated into primary care services like immunization. So these technologies are simple and they're able to give you answers within a short time, and then you're able to onboard these patients onto care. So the question of access is also quite limiting as a factor to both routine and advanced care options. But with the right policy interventions, we could see how that improves. We've seen policies and laws passed in countries like Uganda to enable transplantology as a concept to be a bit more accessible, and the foundations to regulate the practice and ensure that patients who can benefit from it have access to it. Technologies such as red cell exchange do need to have a certain infrastructural, human resource expertise, and supporting structures around them for them to be beneficial. And then we also need to make sure that by strengthening primary care, we reduce the caseload that goes further down. You'll find that there's a difference between disease burden and the availability of services, and where treatment services are available, there's an extreme demand for that, and that tends to limit how much you can do for different patients. So we'll improve the timeline to diagnosis, reduce caseloads and need for advanced care services, and being able to enable access to complex interventions to patients where they need them, and at a scale that is logical for our nation's care system. Next slide. So an important subject, and I think Dr. Mulenga did point to a lot of these points regarding blood availability. If you look at majority of African countries, we are at nearly around a half of the target collections that we need to just meet our basic needs in clinical services, not to mention the increase that comes with provision of specialized services. Most of our blood services are at best able to meet something between 40 to 65% of needs. And this is driven by a number of different challenges across the value chain of blood supply, from collection to production or manufacturing or processing of blood, storage and distribution. And this all comes down to three key factors in the ecosystem. So there are donor factors, there are blood service capacity factors, and then there's the clinical use of blood factors. So I've really listed out a couple of points to look at, from donor education to be able to understand what this gift of life means to the care system and the implications of donations, addressing adverse myths with an aim to modify behaviors around donations, and being able to mobilize and motivate our donors into becoming repeat donors who ensure that supplies can become predictable and blood banking needs can be met. So at the moment, what you get to see is that majority of our countries depend on what we call relative replacements of blood for blood donations. And we need to see how we can transition this into voluntary, regular, and non-remunerated donors, converting first-time donors into repeat donors, so that even as contributing to safety of blood collections, we can then improve our perspectives and situation. Then, in terms of blood service capacity, this is largely a technological question, and I think we did get to see what technology can transform by increasing efficiency, the quality of product you put out, the safety of those products, and sustainability strategies like innovative technology acquisition activities like what has been called out, so that everybody can focus on what their core function is. And then lastly, and very importantly, is the appropriate use of blood, so that we can maximize the potential of what we are collecting. So looking at different clinical specialties that consume large volumes of blood and raising their awareness on when to use blood, timely use of blood, so that your needs can reduce and be accommodated within what's available. Component decisions, safety reporting, so that there can be continual improvement of these systems. So these interventions in those three key factors will go a long way in ensuring that we have blood available for even advanced therapies that we wish to offer to our patients. And I think as we conclude, next slide. In terms of bridging gaps, there are four key areas that I'd like to call out. Number one is primary care strengthening, raising awareness, providing primary care services from screening to medical therapies that impact patient care, and being able to also look at how we can advance what we can do for patients with advanced therapies like red cell exchange and other transfusion methods that depend on clinical presentation. Number two is ensuring that the blood availability question is answered by addressing those factors that we've called out. Access and sustainability from a patient perspective, ensuring that all levels of care are accessible. All advanced therapies for patients who qualify for them are then accessible, and being able to ensure that those services are sustainably accessible to our patients from a financing perspective and of a service provision perspective. And this we can only achieve by collaborating, from a policy perspective, to create an enabling environment, harmonizing guidelines in how we approach things and regulation, care pathway optimization, clinical service provision, industry participating by providing the right expertise, ensuring clinicians are making the right decisions as they utilize their products or technologies, leveraging on patient groups to advocate for the provision of better services for patients suffering from conditions like sickle cell disease. Then resourcing optimizations to ensure that services are where they need to be and are accessible to a consistent standard for all patients. And then leveraging on data from registries, research, and translating our findings into policies that improve that environment. So I think with these 4 measures, we will significantly impact care for patients with sickle cell disease and ensure that those who need advanced interventions can comfortably and consistently access them. I think the last slide I'll leave to my closing remarks on how we can prioritize the different interventions and which pocket of priority we can put them. And I think I'll leave this to my last comments as we close. So thank you, and back to you, Marlos.
Thank you very much, Dr. Iram. Much appreciated. And it's nice to see that there's alignment in terms of vision from private sector, reality on the ground in public sector, and also vision from public sector. So I think the partnerships is indeed the way forward. And I think Terumo has proven that partnerships, even though a cost might seem high, it's not impossible. And I think also private sector is willing to come up with innovative financing mechanism to create that accessibility. And maybe we'll go more into that in the open forum. That's where we'll be now. If you can move to the other slide, Vilda. I received some questions here, and I'll read them as they have come in. I have a first question from Dr. Mulenga, from Dr. Chris Masila from Kenya. His question is, how did Zambia make this business case to the Ministry of Health for this direction for other countries to learn on this approach and use the same model for other types of equipment like Gene Expert? Dr. Mulenga question, how did you make the business case to the Ministry of Health? How did you convince them to fund the setup of this equipment?
Thank you very much for that important question. The first thing is you never to give up and to stay long enough in the service so that you become visible. I've been in this service for 30 years now and done comparisons with other models and demonstrating the folly of other models and how there's discontinuity. I remember we have what very good blood services in Africa that crumbled along the way because of one system or the other. But I think it's just to be persistent and to believe in what you think is the best model and market that, consistently, with the various politicians. You can imagine we've dealt with, I don't know how many ministers over the years, how many PSAs over the years, including change at a very high political level, but we've remained consistent with our message. And I think it's been appreciated. So really it's resilience and never to give up, and also the passion and ownership of the program.
Great. Then I have a follow-up question also from Chris. He writes, also through innovative Terumo BCT equipment, how has it transformed and the blood service effectiveness at the district level? And what about blood screening? Any technologies? So has it trickled down as well? So has it been mainly at the capital center where you mentioned this main equipment is based? What would be your response to that?
For those 2 questions, the production facilities for blood in Zambia are in 10 provinces that recruit donors, collect the blood, process it, store, and then distribute to 200 hospitals. In Zambia, we do not discriminate between public, private, military, and faith-based hospitals. We treat them the same because we believe blood is a public good and it's the responsibility of the government to cater for its entire population. So as an institution mandated to provide the blood safety program, we cater for all the patients and we do not transfer that cost to the patient. So what we've done is to capacitate these 10 centers to be able to collect, test, process, and distribute within their provinces. We are able to do that through manual method using ref centrifuges to produce the components. But as you know, with all manual methods, there are human errors, the quality of the products, the time between when the products become available, reach the patient, that was what was happening. Manual processing methods using the ref centrifuges, mainly the heritage. I would recommend that because it's very robust for African conditions, for manual ref centrifuges, processing of blood components. When the Terumo automated integrated system came on board, we could see the difference in terms of the quality of the product, in terms of the number of units that you can process, 4 units at the press of a button, and you have all these products available. You have your red cells, you have your platelets available, and you have the FFP from 4 units, and the platelets are pulled, and put into one, adequate therapeutic dose with a good platelet yield index. That cuts the time in terms of making the products available to the patient, but also the quality. So what we've done, having demonstrated that at the central, is now go back to government and say, how do we roll this out now to this to the entire of the country? So what we've done is now you would appreciate that the 10 centers act as the storage and distribution centers for the entire country. So what we've done is to advocate for construction of hubs within the province, so that each province will have 2 extra hubs where blood can be collected. I'm not talking about testing for infections, because that should be centralized as much as possible. Whenever you talk about TTIs, the more centralized you are, the better in terms of quality and benefit from the automated systems. I'll be talking about the TTI shortly. But in terms of the distribution and storage, we have 10. Now we're advocating for 2 more per province. So from 10, we're going to move to 30. And we have applied for funding. It was just approved about a week ago. We're just lobbying with the minister so that that budget is not shifted, so that we build 2 more hubs. In fact, we're going to use prefabs, because these are just storage and distribution centers. They just need cold chain equipment and someone to manage the inventory at those points. So that from the 10 distribution points, now by the end of next year, 2024, we should have 30 distribution points. When it comes to testing, we are using the Alinity I. It's also fully automated. I think that's the highest serology platform employed by Abbott. And it's at all these 10 centers. Using the same model of placement contracts, we are also able to process the blood for TTIs in an automated way. As you are aware, its predecessor was the Actect that will do 60 tests per run. The Alinity does 5 times faster in terms of throughput, reducing the time when the products can be available for the patients. And then we have these pathogen inactivation technologies, which we are considering for specific patient groups, like malaria testing, because we don't test for malaria routinely, but we think at-risk patients would benefit from the ultraviolet pathogen reduction technologies in the Mirasol. Yeah, and basically, I think that is how we intend to roll out. It's again getting government putting up a case and the benefits, which has been accepted now. In fact, for Zambia, their presidential priorities, blood transfusion for 2024 has been picked as a presidential priority because it's linked to maternal mortality ratios, and we have one of the highest maternal mortality ratios. So we are riding on the back of maternal mortality to respond through what I described with those hemorrhage protocols, Pack 1, Pack 2, Pack 3, to cover the obstetric patients. But alongside that, all the other clinical areas benefit, including sickle cell, because the commitment is now coming from the principal. That's the highest ruler in the land. It's a presidential priority, maternal mortality and blood transfusion. These are the 2 priorities, our president is focused on. So we have ridden on that to make sure that, we answer this difficult question which you are posing.
Yeah, thank you very much, Dr. Mulenga, and very interesting. Another question is from Florence Ekong, a nurse and professional holistic health and wellness coach, energy healer. I want to ask this question to Dr. Sidoni. Maybe Sheila, you can translate it to the doctor. The question is, what are the key considerations for healthcare professionals when supporting patients with sickle cell disease? He's been doing this research, he's worked with patients. In her view, what are the key considerations for healthcare professionals when supporting patients with sickle cell disease? So maybe Sheila, you can ask it to Dr. Sidoni, and then she can answer it.
Ok, thank you, Malus. Donc, Dr. Sidoni, la question c'est quelles sont les considérations clés pour les professionnels dans le secteur de santé quand il s'agit de soutenir les personnes qui souffrent de prostitution?
Sheila, tu peux reprendre la question, s'il te plaît?
Ok, d'accord. La question c'était quelles sont les grandes considérations pour les professionnels dans le secteur de santé quand il s'agit de soutenir les personnes qui souffrent de la drépanocyté? Est-ce que c'était clair?
Oui, je vais essayer d'y répondre. Je pense bien que c'est de savoir quels sont les professionnels de santé, quelle est la participation des professionnels de santé dans la prise en charge.
Ouais.
C'est un peu ça.
Donc, quelles sont les principales étapes au Côte d'Ivoire quand il s'agit d'avoir le soutien qui vient de professionnels dans le secteur de santé, les docteurs, les personnes dans les laboratoires et tout ça?
D'accord, ok. Pour ce qui est des professionnels de santé qui s'occupent de la maladie drépanocytaire, c'est essentiellement les hématologues qui prennent en charge la maladie drépanocytaire. On avait un centre de prise en charge de la drépanocytose qui était au CHU de Yopougon. Malheureusement, le CHU de Yopougon étant fermé, ils ont été délocalisés au CHU de Cocody, qui est toujours dans la ville d'Abidjan. Mais en plus de cela, il y a les pédiatres qui prennent également en charge les malades de la drépanocytose pour les enfants. Et on a le centre de prise en charge au niveau du Centre national de transfusion sanguine qui prend en charge les complications de la maladie.
Okay, merci. So her response is that they have special various units within health facilities that support patients' journey through sickle cell disease. And in addition to the various units and specialists within these facilities, they also have at community level local healthcare workers that support patients at household level. And then they also have for children, apart from the local community level support, for adults and children, they also have pediatrics support units that specifically target children that have been born or diagnosed of sickle cell disease at an infancy stage.
Okay, thank you very much, Sheila. Merci, Dr. Sidoni. I have a question for Dr. Oyo. You mentioned in your presentation also community level, and I believe kingdom. And question for you is, what role can patients play in advocating for the adoption of technologies, these technologies you're discussing in community? What is the role of patients in this process, according to you?
Yeah, thank you very much. Yeah, indeed, in all our advocacy efforts, we work with civil society organization that comprises mainly of people living with sickle cell disease. We have sickle cell disease association in the country, and they are very, very instrumental in advocacy efforts, even in planning some of these interventions, because they are people with lived experience. They know it all, and when they bring out an issues or the testimonies, it is really a very, very strong tools for convincing the policymakers, for convincing the politicians, and even our partners to give the support that is required. Yes, they are very, very important. They have a very big stake in advocating for issues that pertains the quality of care that is provided to people living with sickle cell disease. So that probably that is what I have. So they can participate in resource mobilization throughout their advocacy efforts, policy aspects, and also improvement in the quality of care that we offer in our facilities through a patient-centered kind of approach and all that. So they have a very big stake and a role to play. Thank you.
Thank you very much. The last question, being cognizant of time, is from Musa Suko. Hiram, this one is for you. As most presenters mentioned, the issue of the kit to be very expensive. Is there any plan of reducing it? Let me ask it. Affordability.
Yes, so very rightly called out. In terms of part of the direct costs that are involved in providing red cell exchange, we do have the kit as part of the overall package. But if you look at the other contributors, or if you do a cost analysis of each of these procedures, you find that a number of other factors come in. Number one, venous access and the options that tend to be available, site of care decisions that are taken by different centers based on the infrastructural components, and then blood and how it gets availed, the amount you need, the processing factors around it, etc. So in terms of direct costs, definitely each one of those has its own contribution. We do take different kind of innovative approaches to try and improve those circumstances, and maybe as part of policy and collaboration with the ministries of health, there are ways in which some of those cost factors can be reduced even before we start looking at affordability. And the thing is that these equipments tend to be imported into markets, and they are subjected to different kinds of taxation. So those taxation contributors tend to increase those costs by, upwards of 50% of the initial kit costs. So are there ways in which governments could support by either reducing or zero rating taxation on some of these technologies? In addition to that, it's also important to give considerations to improvements in the technology. Previously, venous access used to require complex systems like central lines and things like those. But at the moment, I think we do have single needle technologies that tend to reduce the need for central venous access and enabling peripheral access, and hence reducing the requirements around central venous accessing, from costs to site of care to infection control, etc. So all these factors tend to contribute to the costing experience that I think has been reported. There are ways to innovate around how to reduce them, but then again, not forgetting the kind of impact you get from a clinical perspective, where when you optimize the patient's hematological situation, the degree of care that they need, the reduction in complexities, and how that has an effect on the overall system costs. So there are many ways to approach the costing question. And lastly, and I think I've not pointed this out, is the issue around reimbursement and contextualizing red cell exchange, using other experiences like for renal dialysis. How have we managed to bring those costs down? How has access improved, the costing around it? So all those kind of experiences can be used to try and understand how we could rationalize cost factors for red cell exchange. So it takes more of an ecosystem thinking rather than just kit pricing and incident costs. But definitely we are in engagements to see how those advantages can be brought to patients at the end of things.
Thank you very much. And I'm very clear. It's not only the distributor or the manufacturer cost, it's also the taxation that plays a role in the imports, rules, regulations, and the costing linked to that. I'm cognizant of time. I'm seeing it's already in Kenya, 3 o'clock. I want to move to the parting shots. If you could give a 30 seconds key takeaway, Dr. Oyo, what you got from this session that you can share with us as a closing, parting shot.
Yeah, thank you very much, members and all the participants. For me, much as we are really doing well in the country in terms of the sickle cell disease program, we still have a lot of gaps and we need support. And the areas that I highlighted in my presentation, the potential areas of partnership, is where I call on all the different stakeholders where possible to join hands with us to close those gaps and really be on top of the game, because sickle cell disease requires collective responsibilities of all the different stakeholders, and there's a lot of room for us to work together. So that is what I have to say. And as we do this, we put those living with sickle cell disease at the center of our, all our plans, all our budgeting, and all the interventions that we undertake, including research. Thank you very much.
Thank you very much, Doctor. Dr. Sidonie, maybe you can translate a parting shot in 30 seconds, 1 minute.
Okay. Dr. Sidonie, est-ce que vous avez quelque chose à dire en sommaire?
Juste, je voudrais dire vraiment merci aux organisateurs de ce webinaire qui ont permis que je puisse présenter l'implémentation des nouvelles technologies au niveau de la Côte d'Ivoire. Et je souhaiterais que nous puissions continuer peut-être la collaboration pour que nous puissions avoir d'autres technologies. J'ai vu tout à l'heure que Terumo avait d'autres technologies, que nous puissions implémenter ces technologies-là au sein du Centre national de transfusion sanguine pour améliorer la santé de la population ivoirienne. Et merci encore pour l'opportunité que vous m'avez donnée.
In summary, she would like to thank the panel, the organizers, and everybody who made this possible and for organizing this session. And should also like to mention that there is more demand for continued collaboration, and not just in Africa-wide, but even in Cote d'Ivoire, there is enhanced movements and progress towards ensuring collaborations are there. And there is also a greater need for more advancements in technologies for transfusion of blood and improvement of healthcare for all Cote d'Ivoirians. Thank you.
Thank you very much. Dr. Mulenga, over to you.
Thank you very much. Blood transfusion is a bridging science, really. It cuts across different, stakeholders. So it's important that all the stakeholders are well coordinated. I really want to thank Terumo BCT for coming in with such a comprehensive approach to addressing the challenges that blood transfusion practice faces. Of course, there's a focus on sickle cell disease in particular forum, but we can see the linkage that the automated processing and integration impacts on equally important areas such as maternal mortality and provision of those timely products, managing of postpartum hemorrhage, which is a major public health issue. Alongside that, with the technologies, you can now cover different specialties and generally improve the entire healthcare spectrum within a country. So really just a thank you to Terumo for your focus in this area of practice that some of us cherish so much. Thank you.
Thank you very much, Dr. Mulenga. Dr. Hiram, over to you. Parting shots.
Yes, so mine first is to thank AHB for creating this opportunity, and thank you for that partnership. To my co-presenters, thank you so much for your efforts and insights that you've contributed to this discussion with. My parting shots will focus on 4 things. Number 1 is access, primary care strengthening, blood availability, and building expertise in sickle cell disease care for both primary and advanced care options. Number 2 is collaborations to ensure that we're not fragmenting efforts to drive the same objective, how we can bring in our forces into one and have better and more significant impacts on the care system. And then thirdly, we need to enable advanced care options for sickle cell disease patients who require them. So an enabling environment from a policy and clinical perspective opens up the opportunity for advanced treatment options like, bone marrow transplants, which incidentally, a lot of this technology that we're discussing today already offers. And then lastly, and most importantly, There's a patient face behind all these efforts and all these discussions. We saw it at the start. We've seen it through case presentations. For me, just to remind everybody, there's a patient behind all this that's looking up to us to make sure we give them the right service and improve their quality of life. So thank you from me, and looking forward to collaborating.
Thank you, Dr. Hiram. I could not have said it any better, and I will not. I think you've taken a very good holistic closure of the session. For the participants that are still with us, even after official closing time, thank you very much. If you have any feedback, we would love to hear from you. You can scan the QR code that you see on the slide in front of you and give us your feedback, what your thoughts were about the session, the content, speakers, the flow. Basically, we want to hear from you. So feel free to scan the QR code and give us your input, because from input we can learn and grow. If we go to the next slide, I want to basically thank all our speakers, our panelists, and also the CPHIA, the Africa CDC, for giving us this platform in a public health event to also really talk about private sector opportunities or innovations that can scale and improve public health indicators and basically the lives of the people on our great continent. Before we close this session, I want to share with you the save the date for the in-person CPHIA, which will take place next week in Lusaka in Zambia. And I want to share the different sessions that we as Africa Health Business are convening together with our partners. You can see them here online, different topics, different dates, different times. If you want to know more information and register for any of the remaining sessions that we have planned for the coming period, please also scan the QR code to register. Happy to welcome you there. And also want to draw your attention to the Africa Health Business Symposium that we will have next year in Accra in Ghana, that will talk about women's health. We briefly also mentioned here and there public postpartum hemorrhage, the link to the blood issue. That will also definitely come up in our women's health session, which will be in person in May in Accra in Ghana. If you want more information on Africa Health Business or on Terumo, or want to be linked to any of the speakers, please feel free to reach out to me on email or to Dr. Hiram. We're happy to partner with you. And as said, you know, this is a step: awareness, advocacy, making noise, and creating awareness of the issues around sickle cell disease and technologies, and creating accessible, affordable solutions for us on the African continent is key. And we thank you for being with us till the end. And we hope this is one of many engagements and solutions as well. Thank you very much, and have a good remainder of your day.